continuously requiring the oxygen, so that's why the abundance of mitochondria that is there. Now we'll talk about this excitation contraction coupling as you already have done in detail later on, but just to give you the slightest idea, you should be knowing about that how the process of contraction is taking place over here in case of cardiac muscle. So contraction occurs by same sliding filament activity as you have already done in case of skeletal muscle, but it is with some of the differences. The action potential over here actually arises from the pacemaker cells. Now the pacemaker cells, they are where? They are at different nodes like SA node, the sinoatrial node. Then action potential opens voltage gated calcium channels in cell membrane. The calcium induces calcium release from sarcoplasmic reticulum stores, and the relaxation is quite similar to skeletal muscle. Now calcium removal requires calcium ATPase into sarcoplasmic reticulum and sodium calcium antiport into extracellular fluid. So these are actually just the differences which you can see and you should keep in your mind when you are learning this heart in detail. Now cardiac muscle cell contraction is graded, right? We should be knowing about it, that it is graded contraction. The skeletal muscle cell, as we all know, that there is presence of the all or none law, that either it is going to contract or it is not going to contract. The contraction in any single fiber for a given fiber length, the graded contraction occurs. Now cardiac muscle is that the force of the contraction is directly proportional to the sarcomere length. Force is directly proportional to calcium activated cross bridges. So we should be knowing about it, that it is a graded contraction which you can see over here in case of cardiac muscle cell contraction. We'll do this length tension relationship graph later on. We'll do this foxglove for failing heart. This is quite important when we'll be doing the pathophysiology, that how different drugs are going to act and how the high toxic doses of this digoxin destroys all the sodium potassium pump, and low dosage partial block of sodium removal from cardiac myocardial cells. As you can see, the drugs like digoxin, they are being given in case of heart failure. Now the action potential. Well, there is a unique type of action potential in contractile myocardial cells. Now we should be knowing about it in detail. And it is quite similar to skeletal muscle. You can see that there is presence of different you can see that different phases of the graph, they are there. Phase 0, that is actually the depolarization due to voltage gated sodium channels. Then phase 1, there is partial repolarization as the sodium channels close and voltage gated potassium channels open. And then phase 2, the plateau, because of increased potassium permeability and decreased calcium permeability. Phase 3, repolarization back to resting potential. And phase 4, there is stable resting potential, that is of minus 90 millivolts. So all of you are supposed to draw and label it and learn it as well. Action potential in contractile myocardial cells is a much longer. The refractory period and contraction, they end simultaneously. And the action potential over there in case of skeletal muscle, it is about 1 to 5 milliseconds, whereas action potential in cardiac muscle is going to take like 200 milliseconds. So myocardial autorhythmic cells, anatomically distinct from contractile cells, they are the pacemaker cells, and their membrane potential is much less negative, that is like minus 60 millivolts, and spontaneous action potential generation as gradual depolarization reaches the threshold. Unstable resting membrane potential, pacemaker potential, they are actually having the leaky type of cell membranes, and the unique membrane channels, they are permeable to both sodium and potassium. Myocardial autorhythmical cells if channel causes membrane potential instability. Now autorhythmic cells, they have different membrane channels, like they allow current to flow, and they are actually type of channels which actually researchers didn't understand initially. Now if channels let potassium and sodium through at minus 60 millivolts, sodium influx is more than the potassium efflux. Slow depolarization and leading to threshold potential, and then ultimately the pacemaker potential comes and starts at like minus 60 millivolts, and it slowly drifts to the threshold, and you can see that minus 60 millivolt reaching to threshold, that is like much only just drop of minus 20 millivolts reaching minus 40, and then what will happen, that there is the action potential occurs, and this is actually the type of potential which is seen over there in the pacemaker cells. And what are they? They are like the SA node, sinoatrial node, the pacemaker potential that is actually going to start over there. So myocardial autorhythmic cells, channels involved in action potentials of cardiac autorhythmic cells, slow depolarization due to the funny channels. As cell slowly depolarizes, the IF channels close and calcium channels start opening. At threshold, lots of calcium channels open, and action potential goes to positive 20 millivolts and repolarization due to efflux of potassium. So we'll be doing all such stuff in detail later on. This is just the beginning, and this is actually just to give to you the feel regarding the topic of heart physiology, and we'll do all the things together inshallah. And I hope all of you will read it from your book, and try to learn the basic things, and this is very important topic, and with time to time I'm going to guide you which of the topics they are important from examination point of view, and inshallah with good compliance you will all be able to understand this topic and do it very nicely. So stay blessed. Allah Hafiz.